Yeah. Just my take on things. My answer to number 2. Guide discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Cognitive distortion.
All right. Welcome to another exciting episode of Peplau Ghost. Thrilled that you're listening to us, and I am thrilled for this episode. Been looking forward to this for a while. We've got a really special guest, Dr. Kathleen Delaney from Rush University, a real, in my opinion, living legend among PMHNPs. So excited to get her perspective on using psychotherapy within the role. And I am joined with my esteemed colleagues, Dr. Kendra Delaney from Vanderbilt University and Melissa Chapman, who's our program evaluator and relatively keeps us honest so we don't get too much nursing jargon throughout this podcast. So thank you, everybody, for joining us. Quick introduction for those of you who don't know Dr. Kathy Delaney. She is a full professor at Rush University, got her PhD and her postgrad cert at Rush, her MSN at Catholic University, which I'm not sure where that's at, but we'll get into that. It's in Washington. Okay, well, that makes sense for the next one. She got her BSN at Georgetown. And she has a numerous awards, just kind of highlight. She's gotten the NOM, National Organization Nurse Practitioner Faculty Outstanding Policy Award in 2020. She's a distinguished alumni at Rush. She got that at 2018. She was the Psych Nurse of the Year at the APNA, the American Psychiatric Nurse Association, back in 2015. She's been a fellow in the American Academy of Nursing. I'm saying that's amazing since 2010. So that probably feels like forever. That's amazing. And I think she's still an editor. Are you still the editor for the Journal of Children and Adolescent Psychiatric Nursing?
No, I just stepped away from that.
I thought I might have read that, but yes, you did that for a while, and that's amazing. I was starting to write down some of your publications. You are a writing beast, I will call you. You are amazing and an inspiration for writing for me. It's great the way that Rush has linked you to PubMed. So you can go right to PubMed to get all her publications. And what I read was she has at least 130 publications there in PubMed. So that's very impressive. Multiple HRSA grants. I saw 5 on the website, plus a SAMSHA grant and a NINR, the National Institute on Nursing Research, right? At the federal level.
Yeah, we did get a federal grant. Mm-hmm.
So that's amazing. So Kathleen, thank you so much for joining us. No problem. And it's okay, I'll call you Kathy if that's all right.
For sure.
And first question out of the gate is kind of not on their script. I have kind of been doing this for all our guests. Do you remember the first time that you and I met?
I remember that you were a DNP student at Rush.
Yes.
And I was your second or was I your first reader or your second?
You were my second. No, I'm sorry to be testing your memory, but no.
Yeah, I was your second reader. And I think we met in Lou Fogg's office for some reason, because you were in there looking at the statistics from your project.
Yes.
And I remember thinking what a clever project it was.
Oh,
that's
thank you. Yeah. I was looking at pediatric bipolar and such, but thank you. And thank you for being a part of my
No, you were
DNP.
Looking at the diagnostic clarity around pediatric bipolar. It was very complicated.
That's true.
Very nicely done. Sure.
One of my first memories of you, and I will just take this moment to say thank you for being so kind. I was kind of brand new DNP, and we were at the NOM conference, and I was the chair of the Psych Sig at that time, and I was going into that meeting, and you sat down and had a nice little conversation with me, and just kind of checked in with me. That's been something that's been very meaningful for me. So, thank you. So thank you. So getting back to our task here at the podcast, first question for mine is, when did you get interested in psychotherapy?
Well, when I was trained as a CNS, and so that was my training. And at Catholic U, if you remember, Peplau was at Rutgers in New Jersey, and Catholic U was headed by a lady named Garland Lewis. And both of them had worked with Harry Stack Sullivan. So both of them, Garland actually wrote a book called The Interpersonal Communication in Nursing, I think. So that's how we were trained. I'll just say this real quickly. At Catholic U, we went to St. Elizabeth State Mental Hospital, and we stayed with one patient for like 12 hours a week. Just nowadays, you'd say we learned mentalizing, which back at that time, it was just like kind of being with the person and empathy. And then we would write these long notes, and then we would learn, like, did you start to reverberate with the person's internal state? Yeah.
Very cool.
That's my first exposure. And
Thank
at
you,
that
Kathy.
point, I'll just say one more thing. It was all in like the 80s, it was all really humanistic, Carl Rogers, Viktor Frankl. It was really the dominant models being taught, except that we also read for 13 weeks every work of Freud. We read every book. We read them for 13. Yeah. Mm-hmm. So very traditional.
So it sounds like that was really your starts. Were there any forms of psychotherapy that you personally are really drawn to? Like, as your career has evolved, as you've worked with different clients, is there anything that's really called to you? And, if so, is there any, session or experience
Right.
that really stood out to you in that?
Well, when I came to Rush, I actually, from graduation, I detoured into inpatient care, which has always been where my heart is. But for a while I worked at a therapeutic day school and did play therapy and the like. But at Rush, our model was based a lot on a therapist called Michael Bosch, who wrote Understanding Psychotherapy and a couple other books, who in turn was very influenced by Kohut, because in Chicago, the Analytic Institute is very much Kohutian. Aren't you sorry you asked me that question? So I just was fortunate to rewrite the chapter in Suzanne Fitzgerald's book on psychotherapy. And I went into this long thing on Michael Bosch and Kohutian, and I thought, oh my God, they're going to have me cut that. Well, I shouldn't say that on the podcast, but I'm still heavily influenced by that thinking when I see people of self-cohesion and what helps us maintain that sense of self-cohesion. Mm-hmm. So.
Wonderful.
And along with that is Daniel Stern, who I went to a whole course on the Analytic Institute, and from that got interested in Shore, and then from there got interested in Dan Siegel and the interpersonal theory, which is what I taught specifically at Rush for many years, as well as Kohut, actually.
That's amazing. I don't know if this is other people's experience, but I think, one thing that I'm seeing here in the Nashville area is definitely like a strong movement away from analytics, like psychoanalytics. What are your thoughts on that as we're shifting kind of more into this third wave therapy? Do you think that that's, something that the field is needing, or, that we're needing to stay grounded in some of this psychoanalytic work?
Well, I'd hate to think that any graduate of Rush doesn't know what the ego and the tripartite model is. That's always my fear, that they'll go to a meeting and go, "What is that?" So, I think the Wheeler book does a pretty good job of making sure you don't forget that. But again, please excuse me, because I just wrote this book chapter. It was due 3 weeks ago, so of course my head is full of fluff. But there's been a real uptick in the outcome studies on psychodynamic. It's really returning. And for us, I think we need to relook at supportive psychotherapy, which was the kind of bad child of psychodynamic. Like if you couldn't take psychodynamic, they put you in supportive. But actually, Markowitz just published a summary of outcome studies of supportive. And Winston just wrote a book on it. And, it's one of the 4 models that all psychiatric residents have to learn. And I think it has great application. I wonder, I'm not an EM coder. Like, I bet you all know EM codes really well. But the EM code, where you add on psychotherapy and you have to say what you did, wouldn't you love to know how many people put supportive down there? That's my...
I think probably most do. Their 90833 code, and then they put supportive psychotherapy.
I agree. I tell my students all the time, I say the 2 things you'll probably find in most chart reviews, you'll see CBT, of course, and then you'll see supportive. I think that's very common, at least in my area. I'm interested, in regionally where things are at, but
and this is the last I'll say, but, if you really read supportive, you have to have a formulation of what need you think you're. Look at Dan. Dan's like, yes, he's a teacher. You have to have a formulation of what need you're addressing. Like, am I addressing like planning and coping? Am I addressing affect dysregulation? So it's really, you have to have that's where you're going with supportive therapy. So that is a little dynamic, isn't it? Because it's you think that you're looking at the internal representations of the patient.
I think that's such a powerful point. And, even when I'm thinking about some of the therapies that are, becoming like more and more popular, like I'm personally trained in internal family systems therapy. I mean, there's a lot within the IFS realm that's really psychodynamically driven of looking at this internal world and what are the parts of us that are like, what are the needs are they trying to meet? How are they trying to protect us? And that really goes back to Freud and his, formulation of the, he called it something a little bit different than apart, but I really appreciate what you're saying about this really is a foundational conceptualization and framework that I think it is really important no matter what form of therapy you're drawn to be able to be speaking the language and to appreciate that exactly what you just said of just formulating what am I conceptualizing the need of my client.
Absolutely.
Yeah. Thank you.
Oh, sure.
My question is to dive a little into the specifics. I wondered if you remember the first time you performed psychotherapy or just a memorable session that you had that taught you something. Curious what comes to mind.
Well, that first person that I dealt with, of course, is always memorable to me. Oh my God, that brings up so many memories. That's like a psych nurse question because then your whole memory store goes. Probably a young boy I'll put it a different way. A mother I once saw, I saw parents too at this place, at the therapeutic day school, who was very abusive to their child. And I would really listen and just listen to her and kind of accept her where she was, I think. And I saw her for 2 years. And at the end of every session, she would say, I have my bus token because if she came, she got a bus token. And I always thought, wow, she's just coming to keep her kid in our therapeutic school. And then one day she called me after I quit. And I'm like, yeah. And she said, I need someone like you back. I need someone like you that really listens to me every week. I know. And, I'm like at this point, 29, I'm like, you don't know what you're doing then. And I was just like, are you kidding? Just sitting there every day, every week for 2 years and listening. And
it's
confirming.
Powerful.
Yeah. And I always remember her, actually.
Thank you for sharing.
Yeah, that always reminds me, we don't know the impact we have on people, sometimes it's we'll get people in parking lots coming running up to me and I'm kind of like, oh, I'm a little scared always, like, what do you you're looking, do you not want to see me? But usually it's almost always like, you saved my life. And it's just like, gosh, I don't know if I remember exactly what I did besides, put a kind ear or, just kind of listen to you, maybe hold a little space and time for you. But thanks for sharing.
There's a really interesting relatively new article out of Belgium, by Van Dusseldorf. And they interviewed and put in focus groups seriously mentally ill patients and asked, what did an advanced practice psychiatric nurse do for you? I'll send you the article. And really what the patients said was, they were genuine. They helped me accept my illness. I wrote some notes on it. They helped me put things in perspective. I felt acknowledged by them. And I really think that as we have to be able to demonstrate the impact we have on patients. And I think asking, we've been thinking of symptom amelioration, which is important, of course, but I think we need to do many more studies like this to really start looking at the impact that we have in terms of our relatedness and the way we build trust and the way we approach treatment and the way we teach people to live with their illness, which I think we do a lot. Do you think so?
Absolutely. Yeah. I think, and sometimes to a fault, a lot of my students, they'll jump into that educational role. They just love getting into that and teaching people. But I think it's also just being with them and hearing them, being heard. And I think that's where the real learning comes in, but yeah, there definitely needs to be that time that we can devote to that. But
you know what concept I love, Dan? It's an odd concept. It's by Peter Fongai. Right. I pronounced his name wrong. It's called epistemic trust. And it means that the person's willing to take your information. And so providing psychoeducation ain't nothing unless you've done all the ground. What do you think, Kendra? Unless you've done all the groundwork of really getting the person's willingness. I was with an intern of mine, and I shouldn't have said my intern, but he was in my program for a while. And he was talking at a case conference about this patient finally listening to him. And I said, yeah, when did she start listening? And he said, after about 2 years. Like, she started, when I told her she was drinking too much again, she really started trusting me. But it took about 2 years to build that. Takes a long time.
Yeah, I always tell my students, like, you just start with holding space. Like, one of the great things about it being a psychiatric nurse practitioner is we have all these tools of, we can prescribe medications and we can do therapy. And I'm like, we can refer to specialists and to alternative therapies. But, the most powerful change agent we really have is just witnessing people and letting them show up in our rooms and being like, you're not too much for me. Like, you're allowed to take up this space. You're allowed to be here, and I'm going to hold you in your journey and in the space that the place that you're in. And as you said, like with that client you reflected on that, called you back. I've certainly had those too, where I've had times where the clients will sit in front of me. I'm like, I don't know why you're here. Like, I don't feel like I'm doing anything for you. I have my own imposter syndrome coming up. And then when I've suggested, and there's even been times where I'm like, I've named that to the client of, hey, maybe I need to refer you out. Like, I don't think we're making movement. And the client's like, no, just being here is what I need. And so I think that's something that we really can't underscore the importance of, is just showing up authentically as ourselves and then holding space for our clients to do the same.
Go ahead, Dan.
Sorry, Kathy. I mean, you reminded me too when you were talking about, it takes 2 years, and I know, and I know we're not here stuck on a number, but I remember working with a psychologist once who was kind of bent on this idea that a lot of bad therapists need to be kicked out of the profession. And he says a lot of the bad therapists, do super brief sessions. He kind of made the argument that you need at least 15 to 20 sessions to really make any impact on people. And I don't know if that's not true. I mean, I think that, begs the next question, like, who's going to pay for that, and getting insurances and that pushback we always get with them, to provide briefer and briefer sessions. Yeah, it's a struggle.
In Chicago, not that we're any kind of bastion of services, but we still have a couple of really traditional clubhouse models where people, like Trilogy and Thresholds, Dan knows, where people come. So it wasn't 2 years of therapy sessions. It was that this person was engaged at a clubhouse model type treatment and saw this nurse practitioner for medication for a long time. Amazing. Yeah.
Well, I've got a next question. Obviously, as in the initial introduction, you're a nursing leader. And so we'd like to hear from you. How do you see nursing being a leader in performing psychotherapy? Because obviously more than nursing does psychotherapy out in practice. Mm-hmm. That's, I think, one of the things we get, very drawn to this podcast and want to know more about is, making sure nursing stays as a leader, but would love to hear your thoughts on that.
Well, I think that there's two components. The first is the practicalities and the economic realities. Frank just wrote this article, Frank and Gilead, of the economic realities of mental health care. And they pointed out that 9% of psychotherapy is done not by psychiatrists. That psychiatrists make $237, according to the Bureau of Labor and Statistics, about $237 a year. A social worker makes about 78 a year. And they don't separate psych, they only say all nurse practitioners make about 130 a year. And the point is, when you've got, last count by HRSA, we have 900,000 counselors, social workers. They're going to start reimbursing family therapists now, family trained. So you have to look at, there's 43,000 of us now, psych nurse practitioners. My other sidelight is workforce, Melissa, so excuse me. But there's 43,000 of us now and 31,000 psychiatrists. We're going to, so, in the APNA survey, we had 10% of people said they deliver individual one-to-one therapy. 48% said to most patients they deliver combined therapy. What is that? What is that? What are they doing? I want to know. Don't you want to know? So, I mean, I think what we have to do is we have to understand the practicalities, but we have to understand our disciplinary perspective, and we have to make it, externalize it. We have to talk about it coherently in the workforce. And there's only like 3 professions, except for the scattering states where psychologists can prescribe. I don't know how many now. You know, they really consider PAs, us, and psychiatrists as the psychiatric workforce. That's what they call us, psychiatry workforce. And so, you know, our visibility is going to grow. And with that, I think we have to articulate clearly what we deliver. And part of that is what you guys have been talking about, this kind of relatedness, this kind of, like, we need to get outcomes from patients of what they gain from us, I think, and articulate it to people. And I think it will have a big component of our ability of relatedness. You know, there's a Canadian writer that I'd like to send you both a copy of his article, and he has, how are we going to train Canadian psychiatrists? And he has like the traditional model, the familiarity model, which is just giving everyone a broad scope of lots and lots of therapies, and the intermediate model, where you teach 5 core ones, which I think is what we should do. And then the skills within them that you're going to use with a great many patients. So I said that really quickly. So of course, CBT, probably some emotional regulation skills. He lists Socratic questioning for motivational interviewing. So that was a long, you know, I think we have to, like in Europe, they're writing a lot more clearly, like, what is a mental health nurse? Like, I don't know if you ever read Richard Lockman or Sebastian Gabrielson, but they write, like, in the last 2 years, like, what are we doing? What are we about? And they use data to substantiate it. So in order to become leaders, I think we have to articulate our disciplinary perspective a little better, what we do.
You know, it's so interesting hearing you talk about this, because this, you know, feels really parallel to a lot of my colleagues at Vanderbilt and I are, you know, and not just within the psych mental health faculty, but, you know, across the entire School of Nursing have really been talking about, you know, we have this huge push for competency-based education. And one of the conversations we were just having is, you know, the expectation is that we're all moving our curriculums to be competency-based. Mm-hmm. We have yet to even really create name a strong conceptual definition of what competency even is. So when we're talking about, you know, when you were saying, how do we, you know, articulate what we're doing, I think that this is, you know, something that an area that nursing and especially psychiatric nursing it's really a gap, and that I think that we're needing to really work on and hone in on, because if we're wanting to have, you know, have our students prepared to be able to do psychotherapy and tell employers this is a meaningful thing for you to do, we have to also step back and say, how do we make you competent? Like, what, because if you're not competent, then what value are you really bringing? I think that this is just such an interesting time that we're at in the field of nursing education specifically.
You're right. You're right. And, you know, I was pulled this poster that I was at the APNA conference in, I don't even remember where it was anymore, Kentucky. There's this poster, it's using cognitive restructuring in your clinical practice today. You know, and it just lays out exactly how to do it. And should all of our students know how to do cognitive restructuring? Probably. Don't you think? And so I think there's a center. I'm not sure we are going to, this model in Canada says you should pick out these kind of really skills that everyone should have. But beyond the skills, though, Kendra, you know, I want to ask you this question. How much time we got? 1 minute, maybe. But I read this study that in Nature, I read the summary of it, that they're looking at depression being a miscommunication between the amygdala and the hippocampus, which influences the reward system. And that's why you become depressed. You're both shaking your head. You think, nothing against counselors or social workers, Do you think a counselor or social worker could read that article?
Not effectively, no.
Do you think that we have a background in medical? When we study stress and the inflammatory response, do we really understand it? Yeah. Do we teach neurobiology more and more? Do we have a background in genetics? Do we have a background in psychiatry? Oh my God. Do we have a background in psychology? Who's got a broader background epistemologically than us? Really and truly. What articles can you read? A lot. Can't you? Come on.
Absolutely.
But can we articulate that to people?
We haven't yet, right? I agree. I think it's one of those things, like you said, and I think some of it we do to ourselves, but also, as you said, we get lumped into buckets, right? We get lumped into, clinics want a prescriber, so I can pay a nurse practitioner to do less, just like a social worker to do less to do psychotherapy. So there we go. And I've been on interviews where, I've tried to sell my ability to do psychotherapy and, offer those services and been turned down. The employer didn't care about it and said, no, that's why we got social workers here. So it's, but I know, a lot of our students are coming out of school. They're massively in debt and they've got to make a choice choice between sitting in a clinic and seeing 20 patients a day and writing scripts and making, good money versus, sometimes struggling to build your client caseload up.
Right. And, the other thing about the workforce is, and then I'll stop with this because I've been so involved in workforce lately, that there's another thinking that we don't have a workforce shortage. We need much more to match people with what they need in the workforce. And so, I don't know, I think that, is it okay if people do combined? Is that going to be okay? I don't know. Are you going to, do you ever go back to Frank's definition of psychotherapy? It's an intentional, it's a practice where clinicians aim to relieve distress using a particular intervention, and they've been trained in it. That's what Frank says psychotherapy is. So do you have to have long process psychotherapy to do psychotherapy? I don't know. What are you going to say, Kendra?
Well, I was going to say, even when you're naming all of the things that are within the skill set of a psychiatric nurse practitioner, I think by that definition, you could argue that all of those are psychotherapy, even medication prescribing by that definition. I think, I don't know that I totally think that that's a complete accurate representation, but, but I think the point that you're making, and correct me if I'm wrong, but it's just, I think we do kind of have these siloed boxes or ideas of what it means to do therapy. And because based on these, it is, this expectation that it's going to be this really drawn out long process. And, there's going to be a very specific interventions that perhaps are not conducive to a model that, for example, a hospital system or insurance is really interested in reimbursing for. But we also know that that's not, and there is absolutely a time and place for these longer therapies and processes. My area is complex trauma and childhood attachment trauma. So we're not usually solving attachment trauma, in 3 to 6 sessions. But there are also a lot of interventions that we can do that are really meaningful in a short period of time too. And I think that this black and white thinking, I think, is sometimes what scares a lot of providers away from engaging in psychotherapy, where a lot of what I talk to my students about, there's a lot more nuance in what that really means. And I think it's important we're doing evidence-based care and that we're looking at evidence-based interventions, but there's a lot of different options out there. And there's nuance within those interventions as well.
Yeah. Well, I think without that we have larger numbers and, it's hard, Dan. I mean, you did that survey of how we're teaching it, but I think we need to look back on this Canadian model and see if it's a good way for us to think about how we're teaching it, because it will involve a certain amount of skill set development, as it will. If you're really going to teach it will involve, and they have ways to do it too in this model.
Yeah, we had Dr. Kate Wheeler on earlier, another episode, and that was one of our conversations too. Of what are PMHNP programs going to do? Are they going to be very specific, teach one, maybe two forms of psychotherapy, be more broad, And I think we're struggling with that. I think we also struggle as far as the evidence base of what do we do first? Like, do we do, someone comes in with a mental illness, do we give them therapy or do we give them meds? Or do we give them both? I mean, best data says both works best, but not everybody needs some med. And so how can we better identify those people too? So,
well,
all right.
It surprises me. I talked to a friend of mine who is one of the therapists on Better Health, one of those dial-in therapy things that you get 6 sessions and you pay for them in advance. It's really amazing. People are flocking to them with mild to moderate illnesses. So again, I think we have to look at what type of patients are we psych nurse practitioners going to see, and what are the tools for the most part, and what are the tools we need to give people to see those patients. Yeah. But
all right. Well, that's our time. Thank you so much,
thank
Dr.
you so
Kathy
much.
Delaney.
Thanks.
Appreciate
thanks.
it.
It's nice to meet, and it's so nice to meet you. Thank
you, everybody, for joining us.
Microphone off.
Please make sure that you like, subscribe, and send comments to Peplau's Ghost, and look forward to the next episode. Take care.
Thank you so much. Bye-bye now.
Take care.
Too much thought like this, too much seasoning. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.